Thank you for joining us today. My name is Brittany Grant. I am the Director of Business Development at The Hill, and on behalf of everyone at The Hill, I am so delighted to welcome you to the inaugural Future of Healthcare Summit. We're so excited to have you, and seeing so many familiar faces in the audience. We look forward to hearing your thoughts during our audience participation portions of the program and throughout the day. But first, before we begin, we'd like to thank our terrific sponsors, Biotechnology Innovation Organization, BIO, Horizon Therapeutics, and Amgen Biosimilars for making this event possible. I'd also like to extend thanks to our partners in this summit, the American Public Health Association. So let's give them a warm welcome. So in speaking of the future of healthcare, the first thing that comes to mind is the tremendous amount of transformation taking place within the American healthcare ecosystem. Medical breakthroughs and advances in technology are creating new pathways for delivery of care. A new generation of medicines has the potential to enhance patient experience, and stakeholders in the healthcare space are designing new tools to help people take charge of their health. But issues of access and affordability continue to be top of mind for patients and policymakers alike. The new age of healthcare brings with it the promise of a healthier tomorrow, but it also raises some vital questions. We have some excitement outside. How are healthcare leaders working to ensure that patients are at the center of all innovation? What measures will support more efficient healthcare expenditures? And how can this innovation pipeline be sustained? And what policy measures can ensure the benefits of research and development are reaching all consumers? We'll be hearing from some of the most respected names in healthcare on topics including innovative technologies, new models of care, the role of data, health inequities, and the future of public health. We have a few quick housekeeping notes here. So in addition to our audience at the Longview Gallery, thank you for joining us. We are also live streaming on thehill.com, so please keep your phones on silent throughout the duration of the program. But we do encourage you to engage in conversation on social media. You can do so by following us on Facebook, Twitter, LinkedIn, and Instagram, by following @TheHillEvents, and join the conversation using the hashtag #TheHillHealthSummit. We're going to be taking some questions throughout the program and are eager for your participation, so please be on the lookout for members of my team with handheld mics. And finally, you will receive an electronic survey following the conclusion of today's event. We're always here at The Hill eager to see how we can make our events more dynamic and engaging, so I encourage you to take a few moments at the end of the program to provide your feedback. And on that note, it's time to get the program underway. So please join me in welcoming a senior member of the Senate with a strong view on what the future of healthcare looks like. We are glad to have Senator Joe Manchin joining us for what will be a fascinating conversation with the Hill's editor-at-large, Steve Clemons.
Hey,
Senator and Steve, over to you.
We'll have a few people, so it's going to be more exciting than you think. Thank you so much for joining us, Senator. Today, what our challenge is to get a sense of what the health picture is for the country and what it ought to be. You're one of the people helping to shape what it ought to be. What is the dashboard of concerns that you have on healthcare today?
Well, I don't know if people really have come to the understanding of how much money we spend on healthcare in America. We spend almost as much on healthcare as we do our national budget. Over $3 trillion, about 3.7 to 4 is about what our national budget is, and we're about 3.4. Spending that type of money, you should get better results than what we're getting and be ranked where we are in the world standing of health and wellness and longevity. It doesn't give you a return on investment. So what's wrong? The elephant in the room is basically that you have 5 to 10% of the people, elderly, end of life, chronic illnesses, that are taking about 50% of the money. So unless you're going to say, okay, how do we take care in the most compassionate, humane way? And that's where we had the reinsurance. We had basically, Alaska has done something that we thought was very good. We've had 2 bills laying on Mitch McConnell's desk for a couple years now? And those 2 bills will reduce the private payer about 30, 40%. Can't get them to move on it. So I guess, we're so toxic as far as the political environment that it's better to blame somebody than fix
So
something.
are you suggesting we re-weight away from that weight of the chronic, we just had a program this morning where that came up, was the growth of chronic illness and longevity of Americans. Do you think we should walk away from that?
Not at all. Basically what we've said, it's basically a reinsurance pool. And that pool should be every responsibility of every state to participate in. Use your Medicaid match, whatever we can do to give them leverage. But they have to make commitments to that. We all have a moral responsibility. And with that, it'll be, you have to make insurance affordable to those people end of life. They have to pay something too if they can. And with that, we've tried to keep that down with the ACA, pre-existing condition. We got the Texas case right now. If that thing goes through and the courts uphold that and the Supreme Court rules on it, we're screwed as a nation.
Now, you're not a fan of the Affordable Care Act.
I was not a fan of the Affordable Care Act when they did it. When they called me, I was head of the National Governors Association. And I'll never forget, I was on the phone. I had about 9 other governors with me, 5 and 5, 5 Ds, 5 Rs. And we all had a challenge. And, I was back governor when Mitt Romney did his plan in Massachusetts, which I thought was a great idea. I was there when Jeb Bush did Common Core. I thought that was great. But every state's different. We try to look at what they were able to do with the economies they had and try to adjust it to ours. How do we get more people insured and covered? It's better for all of us. With that, I said, now let me make sure I understand. Max Bach is called, and Max is a dear friend of mine. He says, everyone has to buy. It's mandated, buy insurance. And we're not going to give you any choices at all. There's one policy you have to buy, and this is the price you're going to pay for whether you like it or not. And if you don't pay for it, we're going to fine you. I says, Max, that might work in Montana, but I can assure you it's not going to work in West Virginia. I just didn't think that's who we are as a society in our state. You're not going to mandate. So there's no options, no incentives. If you drive a car and you're a safe driver, you get a discount. You're able to negotiate something. That should be what we should be doing. And we started out with, I guess they got what they could pass is what it really came down to. I said I wouldn't have voted the way it was coming. A lot of the things are great what they did. Taking the caps off to where, you're too sick, I'm sorry, you already used all your money. You're going to be paying 5 to 10 times more because you're older. All those crazy things, pre-existing conditions. Insurance companies can play God and say, I'm sorry, you're too expensive for us to insure, too much of a risk. We're not going to be involved. Those were all things that should have been done with a long time ago. So that's all good. Now that we have it, you can unravel it. You unravel it now, you got a third of our economy will collapse. And I don't know if they're ready for that. I don't know how we handle it.
A good chunk of your colleagues are running for president. You see them every day.
We're having a hard time getting a quorum now.
Yeah. And a good number of them are all of a sudden for Medicare for all.
Yeah.
What do you think of Medicare?
We can't even pay for Medicare for some. And to go Medicare for all, we can't take care of those who are depending on it right now. And it's going to be going. You're not working?
Yes, I'm not working. Go ahead.
Okay. So I've said that. I said, listen, that's an inspirational, novel idea. And they said, well, the whole purpose of Medicare for all is once you hit the golden age of 65 and you qualify for Medicare, we don't care what pre-existing condition you had. We don't care what your health care situation is. We're going to take care of you. You got it. That's the concept. Well, can't we continue to do something along the lines? But if you said, one-payer system, Medicare for all in America, there's so many people sitting in this room right now that we are kind of conditioned. You want what you want when you want it. And if you're willing to pay for it and make that sacrifice, then by golly, in the capitalist society, you should be able to buy it. And we're going to take that away. We're going to take all the unions away who've negotiated their contracts, these Cadillac plans, if you will, really golden parachute plans. I don't think that our society it's going to divide us too much. And it's divided now. You can have both. But until you take care of the end of life and you take care of your highest cost in the most humane, compassionate way, you're not going to fix the other 90%. You're just not going to do it.
One of the purposes of today's forum is to bring in a lot of the stakeholders in the healthcare ecosystem. We've got hospital representatives, patient advocacy groups, pharmaceutical firms, folks doing generic side, biosimilars and generics, and just everybody. And I guess the question I have is, among your colleagues in the Senate, are they making what I would see a choice between, on one hand, the kind of science ecosystem, getting advanced drugs in place, working with universities and NIH and the whole science equation, if you will, of advancing us forward in a genetics revolution and beyond on one hand versus cost, access, affordability on the other. And I sort of see that bubbling up as a choice. Do you think that is a fair depiction?
Well,
and how do your colleagues look at that?
The reason-
Are they willing to forfeit?
Well, let's say.
I mean, this morning, Jim Greenwood of Bio made the comment, says he worries about support for biomedical research and that ecosystem continuing in this fragile time.
Yeah, it really shouldn't be either or. The reason you're hearing so much about the cost of drugs, prescription drugs, is because most of it you have to pay out of pocket. Big co-pays or pay out of pocket. Healthcare, you don't hear as much. And as much as we spend on drugs versus what we spend on healthcare, is not even proportionate. But we raise more hell about the drug prices because that's something we're paying for. And you figure out, well, why can I go to Canada or why can other countries have it much cheaper? Look how our drugs get to market. Look at the research and development, bringing a new drug on, or if it goes generic, how it goes and what hoops it goes through to get to market. There's not another country in the world that puts their product on market the way we do. Not another one. PBMs, the whole distribution system, everything. And it basically just jacks up the price unbelievable. And it has to be taken care of if you're going to basically bring the price down. And that means taking on the powerful people who roam the halls. Probably some of you on here, aren't you?
So I know President
Nothing
Trump.
personal here, gang.
Yeah, I know President Trump calls you at odd times.
Oh, yeah.
And how do you know it's him? Does it say like,
Well, you get
that Donald is calling or what does it say on your phone?
We have a strange relationship.
Yeah, but he does call you. I mean, and he calls you quite a bit. Do you talk to him?
I'm a conservative Democrat, and he's a conservative Democrat. He just put a label.
Yeah.
And he just put a label by himself as being a Republican because he thought it was a better pathway. So every time I would see him, he'd say, "Joe, why don't you just change?" I said, "Mr. President, why don't you just change back?" I said, "We can work it. We can work this thing out in the middle somewhere." We have a very good relationship.
But you guys talk about drug prices. You talk about the healthcare ecosystem. So
talk about immigration. We talk about everything.
So does he listen to you?
Well, I'm sometimes not the last person in the room.
And what do you share with him?
I'm going to try to be scheduled the last time. Maybe I can have more time.
But I mean, when you talk about kind of getting this ecosystem right and tweaking things, what are you telling him to do? Particularly within the regard of your West Virginia constituents.
Well, first of all, I said, he keeps saying we got to repeal. I said, Mr. President, why don't you be the Mr. Repair President, Mr. Fix It? We'll call it Trump Repair Care. Because you cannot throw this out. Do you understand the people that voted for you and elected you are the people you're going after? You can't do that, sir. I said, look at it. So we try to break this down, but he thinks a political promise is a political promise and held with the consequences. And I just, he campaigned against me. I ran in 2018, and he won my state by 42 points. If you can imagine me in an R42 state. And he came after me, and he says, "Yeah, I like Joe." He didn't have a nickname for me. He just said, "I like Joe." And he said, but he never votes with me. I voted two big things I thought he was wrong, and I still think he's wrong on. Doing repealing health care and the tax overhaul. I said, Mr. President, we're the superpower of the world. You can't go down 15, 20%. You can't do it. You can't pay the bills. I said, we can fine 25% fine. And some of the top end of the food chain, we can make things work there. They're still going to be fine. But man, you're putting a crimp on some people, and we're $23 trillion and growing $1 trillion a year. We haven't seen this type of public debt, since World War II. And you thought 27, 28 was bad? You haven't seen anything yet if this one hits.
Of the Democratic contenders who are going to be on stage on Wednesday and Thursday night, whose health care plan do you most support?
I think all of them, and I will say this.
All of them? Bernie?
No.
Yeah.
I think all of them realize that what we have with the ACA needs to be fixed. Now, they're talking in their grand plan of what they want to do, but then it has to come to fiscal responsibilities. How do you do? Because there's major changes. It's easier to fix what we have, and we got enough things that we know that works well and enough things that we know that don't. And let me just tell you about health care. And I come from a state where you had to get up and work every day. If you could work, you had to work. I mean, there was no loafing around. I come from a little town, 400 people in Farmington. I never seen anyone sitting on the sidewalk. Everybody worked. Everybody did something and pulled their own. So I said, let me ask you something. I said, you know what? We just gave the most expensive gift you could give a human being, a health card. 180,000 West Virginians. I says, I can go and buy a box of Cracker Jacks, and I can get the prize out of the Cracker Jacks, and there'll be a little instruction of how to use that little prize. We gave you the greatest gift and gave you no idea how to use it. I got people that never had health care that was going to the emergency room, and by God, they're still going to the emergency room until we stop them. We don't have any preventive care. We don't do anything at all. I said, that's the low-hanging fruit. If that's the low-hanging fruit, then why don't we go back and try the instructions? Mandatory. And if you abuse it, you're going to lose it. This is a privilege. This is American people making a sacrifice for those who are less fortunate. We want you to have good health care. We want you also to have some skin in the game. Your skin in the game is to be educated on how to use health care, literacy. So we haven't done any of that. I'd like to see but they're going with all these new grand plans. They're using all these social programs around the world. You know, we're not a social.
So I want to go to the audience and get at least one or two questions real quick. But before I do that, I interviewed Senator Ed Markey, another one of your colleagues who's not running for president, though it sort of sounds like he is sometimes. But he said that we need to double the NIH budget, that we're pussyfooting around science, we're acting like it's incremental. But he said we're at a point right now where we're on the verge of so many fascinating genetic breakthroughs that could be completely transformative for the health ecosystem. So why aren't we just doubling the NIH budget?
This is my opinion on, we can be throwing money at anything and everything. NIH needs more. But NIH needs to have a timetable. When you're going to bring something to market. And I'm a big believer in public-private partnerships. You put private money involved with public money, the private money says, listen, I got a timetable here. I can only be at this, so I got to get some return on investment. The public sector, all my universities, WVU, all of them, there's no timetable. It's just 10 years old, it's wonderful, another 5, but not going to hurt anything. It might go over an extra 5, we're okay. That's not what we need answers. We need solutions. You put public-private, and you give the private companies basically incentives to invest into the public companies, and you let the private drive the incentive as far as time sensitive, you'll get things done in a much better, quicker way, and I think better results.
Real quick, last question before I go to all of you. When you look at your constituents' concerns out there, whether it's Mueller and the Russian investigation or infrastructure, what's the number one issue that your constituents are worried about?
In West Virginia, survival, jobs, basically. We're in an extraction industry. I mean, our state basically has been a heavy lifter. We have, I've said this.
So jobs. Does healthcare come in the top 3?
Jobs and family. Opiate addiction right now has been absolutely horrendous in our state. And if you have an education system, you have a program to where you can keep youth involved. I don't think a child should be graduating from high school without an associate degree of some sort. They're either ready for work or ready for higher educational learning. We're not getting a kid even in vocational training almost until they graduated anymore. This is ridiculous. We lose them at 18, 19. They flounder around. Oh, they'll go to college because someone says, oh, yeah, you're college bound. Well, look at the price. Look at the debt we're dealing with and everything else that goes with it. We're not getting results. Do you know a registrar cannot refuse you the money if you qualify because of your family income? And you go and you have a Stafford loan. They says, oh, Stafford loan, sure, here. Let me see, what's your family income? You qualify for $12,000. You only might need 6. But for the first time kid, 19 years old, 18 years old, give me all 12. And by 2 years, you're up, you're $25,000 in debt. You're out of school, you've done flunked out. You're on your own out there. And now you got to start paying it back because you're not a full-time student.
So you've just given me topics for 4 or 5 more summits. Which the Hill will be at over the next year. So let me just at least get one question or comment from the audience. Yes? Oh, that's our rapporteur. Yes. Somebody want to ask Senator Joe Manchin? Yes, right here in the front. And let's get you a microphone. We have lots of folks watching online, I've just been told. I believe in football passes. You can just toss him the mic. No, I'm just joking. Thank you. Hey, tell us who you are.
Jim Thomas. I'm a physician. And I don't know how many physicians there are out here.
More than you think.
The opioid crisis in West Virginia.
Yeah.
We've pointed out that it was one family, the Sackler family, that bribed the FDA to have them say that it was less addictive than other medications. And since they bribed the FDA, that's fraud. and you can pierce the corporate veil and go after their art collections in the Metropolitan Museum.
Turn in a quick question.
Are you going to be doing that in West Virginia? We haven't seen you guys do that because you should be able to pay for all the, help get these people
I've
out
got
of the medical.
So Sacklers, opioids, and what are you going to do?
Well, if I was still governor,
Yeah, might that happen?
good.
Yeah, could.
Let me just say this.
That was
It's
news.
it's a shame that the state of West Virginia has not gone more aggressively. They're settling cases for pennies on the dollar. It's awful, and I've told them, Attorney General. Of course, Attorney General's got ran against me too for U.S. Senate, but with that, he says that's the best deal they can get. I said, crazy. We got $800 million for tobacco settlement in West Virginia. He just settled with one of the distributors, I think, it wasn't Cardinal, I'm not sure which one of the big ones, the distributors, for 30-some million. Thought it was a good deal. Let me tell you, I have a bill out. It's called Lifeboat. Now, we don't have enough treatment centers. I've got parents come to me and says, please, I hope they arrest my child. And I said, what? I want my child to be arrested and go to jail because that's the only way I'm going to be able to get them into drug court to get them to save their life. When you have a parent begging you to arrest their child, and most of it's for larceny, they steal to support their habit. So I have a bill called Lifeboat. I want to charge every manufacturer that wants to make this horrific drug that should not be on the market, should have never been on the market the way it is, a penny a milligram. 1 penny a milligram that goes into treatment centers only to start getting people cured, the treatment they need. That would raise $2 billion a year. That 1 penny, that's how addicted we are as a nation. Can't get one of my Republican colleagues to sign on to it. He says, no new taxes. I said, you didn't have any problem signing on tobacco.
Senator Cassidy's up next. You can chat with him.
You had no, on tobacco tax, you had no problem signing on to alcohol tax. I'm asking for basically a production fee. It's not going to be a tax passed on. We won't let them. Having a hard time.
So real quick, just finally, which seat do you like better, your Senate seat or your governor's seat?
Governor's best job in the world.
That will end it right there. Ladies and gentlemen, Senator Joe Manchin.
Thank you.
Thank you, Senator Manchin and Steve. Now, please join me in welcoming to the stage Senator Bill Cassidy and the Hill's Editor-in-Chief, Bob Cusack.
Thanks for joining us. Nice crowd today. This is a long day healthcare summit. When you talk to your constituents in Louisiana, what's the biggest healthcare issue they mention to you?
Well, it is what they say, and it is the underlying issue that
Okay.
I would interpret from what they say. What they say is the high cost of medication. It is surprise medical billing. It is the fact that they think they're going to an in-network facility, but indeed it is an out-of-network bill that they then receive. I would interpret that by saying that the patient does not have the power. CBO, I was talking to the new director of the CBO recently, and he said in the healthcare marketplace, every entity has market leverage except the patient. And when I'm receiving these complaints, the unifying theme is that the patient has no leverage. So I think I'll tell you that which they tell me, and I will tell you that which is the underlying theme.
You mentioned surprise medical billing. There's legislation pending in the Senate. Do you think that the parties can come together? I know you've introduced some drug pricing bills, bipartisan. Senator Durbin's on it. Where do you see healthcare legislation going in this Congress? And does it, if anything's going to move, does it have to move very soon? Because as you know, the 2020 debates start tonight.
So a couple things. You've had 2 or 3 questions. Oops, is that me?
Yes.
You had 2 or 3 questions kind of mixed in there. First, we have, I think, 13 different amendments that are incorporated or will be incorporated into the final bill, and all of those are bipartisan. I think all of them are bipartisan. And the fact that Alexander and Murray have agreed on all this means that something can be done. Now, on the surprise medical billing, which is another issue, the one that we put together, I say we, Maggie Hassan, Michael Bennett, Bill Cassidy, and a few others, Lisa Murkowski has now, I think, 26 co-sponsors.
Mhm.
So clearly, we can get together. That said, the one that has 26 co-sponsors is not the one that's incorporated in the bill. That is one that's been agreed upon by Alexander and Murray between the two of them. So yes, we can get together if you mean Democrats, Republicans. Yes, I think something will pass, and ideally, it'll pass from the Senate floor by the end of July.
Do you think that healthcare, I mean, the parties do work together on some issues, opioid crisis, but obviously they have not worked together on the Affordable Care Act. Do you sense that's changing? And the second part of the question, because I always have a couple, is when are we going to see the Republican unified healthcare plan?
So the Affordable Care Act is obviously a third rail, but people will touch it without realizing they're touching it, and nothing happens. So, for example, the administration has put out a rule for association health plans, and it will reduce premiums by anywhere from 20 to 50% in some markets. 20 to 50%. Now, of course, the usual suspects talked about how terrible this was, da-da-da-da-da-da-da. And then it flowed across my desk yesterday, an article from Colorado, a small ski town where the Democratic insurance commissioner has put together a negotiating coalition of small employers, effectively an association health plan, and they've renegotiated their rates with the local hospital 20% less. And I thought to myself, as long as it doesn't seem to come from Republicans, Democrats understand the wisdom of this idea. And so I do think that there is going to be some issues where we're going to find common ground, if only by accident. You know, you go to a fight and a hockey game breaks out. So there are some things we still can't touch, but the fact that Democrat candidates are calling for Medicare for all clearly indicates they understand there are incredible flaws with the Affordable Care Act, and they would like to scrap it. I think I can say I've recognized those flaws for a little bit longer, and I would like to address it as well. Hopefully we can come together on that.
Republican health care plan, when we see that?
So it is clear as conservatives, well, let me start over. Conservatives don't think, oh my gosh, let's just toss everything out and then start anew. It's rather that you should systematically change, allow the system to adjust, and then change some more. And I think you can see some remarkable things that Republicans have accomplished, even though they may not be acknowledged. The association health plan is one of them. The individual mandate, which, by the way, Jonathan Gruber, the guy that wrote the Affordable Care Act, published research after it was passed, published in the New England Journal of Medicine, that says that the individual mandate did not increase coverage. Now, this is the guy that wrote the Affordable Care Act, doing the research that showed that it did not increase coverage. New England Journal of Medicine, just Google it. But what did it do? Those people who could not afford insurance were paying a penalty. It wasn't poor people, because they were on Medicaid or they were otherwise getting covered. Rather, it was the middle-class family that was not getting a subsidy that was paying a penalty. So that's another component of what Republicans have done. And I think you'll see this kind of evolution to where we get to a marketplace, if you will, that the patient has the power. Not somebody in Washington, D.C. telling you what you have to do or else you get fined, but rather the patient who will be activated, making the best decision for her, her family, for her physical health and her financial health.
Big picture, what is something that is you're hopeful about, you're a physician, about the future of healthcare, and what keeps you up at night that's a problem that must be solved? Some people say it's solvency. Medicare is going bankrupt.
First, one thing I do see on a bipartisan basis, we've been working on price transparency. 3 and 3 have been working on this. The president just put out an executive order that is going to push for price transparency. Now, hospitals and providers don't like it. And the bill that we're working on with Murray and Alexander right now, there will be a provision that says that providers cannot gag the insurance company so that the insurance company cannot tell you the lowest cost setting of care. Let me give you a palpable example. Really palpable. Imagine you're having a colonoscopy, okay, bring your head back. You can go to an ambulatory surgical center and have the colonoscopy for $1,500 all in. You can go to Hospital 1, and Hospital 1 is $2,500, and Hospital 2 is $4,500. All three are in-network facilities, but if you have a co-insurance of 10%, it's $150 there, $250 here, and $450 at the last place. You should know that. Right now, you are gagged. The insurance company is gagged and not allowed to tell you that. The patient should have the power of knowing the price. So one thing I see very hopeful on both the right and the left, and in the executive orders and in the legislative branch, there is a push for price transparency. I can tell you, people say, oh my gosh, that's terrible, the patient can't handle the knowledge, it's against her self-interest to know the price of something. Yeah, right. Yeah, right. And that's assuming that the current marketplace remains as it is. We can all imagine that one day there might be an Amazon Prime Health that you can go on and get your services at the lowest cost with the best quality. A friend of mine has a website, buildmybod.com, where you can go on and find the cash price of various procedures. I see that hopeful. In terms of what keeps me up at night, clearly the insolvency of Medicare has to be of a concern. The actuaries say 8 years from now, it's gone. At that point, it becomes pay-as-you-go, and providers will be paid probably 25% less than they're currently paid. They're just not going to stay in business. Whenever folks speak of Medicare for all, depriving 150 to 180 million Americans of the employer-sponsored insurance that they like, the heck with if you like your insurance, you can keep it, and put into Medicare a program going bankrupt in 8 years, I think that once there is Medicare for all, there will be Medicare for none.
How can the disparity between rural and urban healthcare be fixed?
Yeah, that's a big, big issue. Very complicated in one sense. First, it's financing. One of my concerns with the way that the surprise medical billing provisions of the current legislation going through the HELP Committee is shaped up is that sometimes rural hospitals need to charge the commercial patients a little bit more because their payer mix is so poor. There's a lot of Medicaid, which pays below cost, and some Medicare, which pays about cost. But so if you have a lot of Medicaid, you're not making your cost. So the way this is currently in the current version, the insurance companies are basically setting the rates with no pushback from anybody. So I do think that will put some rural clinics out of business. That said, another issue is how to get providers there. Well, telemedicine actually holds great promise. So if you have a patient with a stroke that goes into an emergency room, a neurologist is not there, but you need the neurologist to give the order to push the clot buster, if you will. By telemedicine, you can arrange that so that the neurologist 100 miles away in the urban center can, by telemedicine, give the order, yes, it's indicated, yes, give it, now let's follow this patient together. So telemedicine will be part of that. We need to be, though, increasingly innovative how we approach this.
But with telemedicine and telehealth, how important is broadband? I mean, everybody in the Acela corridor thinks everyone has internet access, but that's not the case.
It is not. I am on a separate issue interested in the economic development aspect of how do we get fiber optics out to the rural areas. The haptics are important, meaning I think I understand haptics to be the lag time between for example, you're doing surgery, it has to be real time in terms of you push this button and the scalpel moves. On the other hand, when it comes to something such as a diagnostic, okay, the patient's having a heart attack, we need to push the medicine to lyse the clot. That's not quite as precision. That can be 30 or 45 seconds delayed, and it won't have an appreciable difference. It's one thing if you're running a code. Bob, his heart has stopped beating, we need the paddles on, but you would have providers there to put the paddle on you so that you would otherwise be saved.
We've got a few minutes left. I want to open up for questions. If you have a question, please raise your hand if you can identify what group you're representing, if any, then, and also wait for a microphone to get to you. One over here.
Hi, Ellen Milheiser from Synopsis Newsletter. To expand telemedicine, do you intend to do anything about the licensure of providers and allowing them to operate across state borders?
So that's a really interesting question. Again, licensing of providers across state borders. Now, on the one hand, you can have radiologists in Australia currently reading x-rays that are done in Louisiana. And so we do have this because, they're on the other side of the clock, and so therefore they can be up at 2 in the morning for us, but it's 2 in the afternoon for them. I think it's still required that they get licensure in Louisiana. Now, the reason I say that is that different states have different criteria. It is hard to get a doctor to move to Alaska. I should probably say more properly, it's hard to get the doctor's spouse to move to Alaska. Nothing against Alaska, but oftentimes spouses wish to live in a place which is stimulating, and they may find, being in a very rural area in which you have to fly to a small town for your nightlife is not as stimulating as they like. Docs tend to find their practice stimulating, so you just have to kind of take that into account. So Alaska probably would allow a physician to practice there who is not board certified, for example. I don't know that, but let's just imagine. Now, every doc almost would love to live in San Francisco. So California has higher barriers for licensure. So I think you do have to respect the state's right to lower or raise their barrier as regards who comes into their state. On the other hand, the fact that a doc in Australia can be reading a film from Louisiana shows that the current system can work if you just make a little bit of effort to get licensed in more than one state. So,
We have run out of time. You have been a regular at our Healthcare Events Center. Thank you so much. Please thank the Center for joining us this morning.